Hi, hello. Welcome back. Let me discuss an interesting case which I encountered yesterday. Patient presented with seizures, and we have performed an MRI brain. This is an axial T2 weighted image. You are seeing a broad based or a dural based lesion which has a broad base towards the fox, and the lesion actually is causing the gray matter buckling, and you are able to see this clear CSF cleft between the lesion and the brain parenchyma. These are all hallmark features of a meningioma, which you should be aware of. And the lesion also was indenting on the corpus callosum, cingulate gyrus. So this is a classical case of meningioma. Whenever you want to confidently diagnose a meningioma, you have to look for certain signs. Contrast, you are able to appreciate classical dural tail sign. So this is the dural tail. Thickness is greater than 2 mm. This is one criteria you should be aware of. And you should in swan there were no calcifications or hemorrhagic areas. And most importantly, whenever you want to grade meningioma, you have to look for that diffusion restriction and parenchymal invasion. In this case, there was no diffusion restriction. ADC is normal. So extra-axial, broad-based or dural-based lesion with the characteristic signal intensity patterns, vivid homogeneous enhancement, CSF cleft sign identification. In this case, it is not relevant, but normally if it is on the convexity, you have to look for that hyperostosis. These are the features, and sign like dural tile sign can be seen in around 60 to 72% of the individuals. What I want to tell you, it's not pathognomonic, but because it's seen in 72% of the individuals only. It also can be seen in metastasis and lymphoma, other dural based lesions. Diffusion restriction is for grading of the tumor. Most of the meningiomas, there will be increased RCBV in which is ranging from 7.16 to plus or minus 4 will be there. There will be increased, and alanine peak is seen in meningiomas, which is seen around 1.3 to 1.5 ppm. So typical one, it shows homogeneous enhancement, sharp tumor interface, and no restricted diffusion. I still, though there is some degree of necrosis, I call my case as a typical meningioma grade 1, easy to resect. There was no irregular interface. Differential diagnosis, solitary fibrous tumor hemangiopericytoma, which again may show diffusion abnormalities. There can be more of bone destruction. So this is sensitive sign, dural tail sign we should be aware of. And sunburst pattern will be seen in case of angiography because of hypervascularity. And recently there is one more sign called ginkgo leaf sign, which is identified in case of spinal meningiomas. This is an interesting article which has been telling about that ginkgo leaf sign, especially in coronal MRI. If you see, this is looking like a typical ginkgo leaf. This can help you diagnose. And this is the ASL perfusion, where you can see there is a increased perfusion in our case. So these are my references. Thank you very much for your attention. Hope this video on meningioma and extra axial lesions was useful for you.